My name is Joseph Deferio, and I'm a health informatics investigator at Weill Cornell Medicine. And today I'll be talking about methods for integrating electronic health records, social determinants of health, and built environment data for patient-centered research. Why social determinants? Well, according to this recent framework, which was published by the County Health Rankings and University of Wisconsin Public Health Institute in conjunction with the Robert Wood Johnson Foundation, social and economic factors may contribute to up to 40% of health outcomes. And those include education, employment, income, family and social support, and community safety. Many of the icons on this slide may look familiar. You'll see Apple and Fitbit and social media platforms, Weill Cornell, housing, and your NYPD, and they all represent potential sources of health and wellness related data. And what we're finding is that it's becoming more ubiquitous and available electronically. And health and wellness related data is no longer limited to clinical settings, whereas the data on the physical, social, and digital environments is coming to the fore. So many of the data elements that I just referred to are known as social determinants of health. And these are, broadly speaking, digital and online behavior, such as social media, weather, air quality, environmental factors, interpersonal interaction, crime reports, and fitness and activity trackers. Better yet, these data elements should be referred to as social influences of health because their incorporation and effect on your life is not deterministic. So the main thing we're trying to answer is we all know that neighborhoods and communities such as the physical and or digital influence our lives, but what we really want to know is how do they influence us and what is the magnitude of that influence? So our work was motivated by past work that has investigated the influence of one's environment on health outcomes. One study concluded that the access to public transportation in dense urban structure could reduce risk of depression. That study took place in Turin in Italy. Another study concluded that long-term exposure to environments that support physical activity and healthy diets is associated with lower incidence of type 2 diabetes. So it is our feeling that now, more than ever, health systems are uniquely poised to begin to answer some of these questions. Why? Because health systems have access to patient health records, publicly available data such as public-private entities and government collected. They have access to informatics and data science teams, and they're generally located at the center of all these different elements. So the objective of this talk, the primary objective, is to address the knowledge gap and achieve a more comprehensive electronic health record data integration and linkage that incorporates a broad spectrum of information about SDOH and built environment across New York City. Some public, private, and academic institutions have already begun collecting and disseminating social determinants of health data. Here you'll see New York City census tracts, which there are 2,165. Each tabulation area has an 11-digit FIPS code correlating to state, county, and census tract. You'll see an example of that below here, this 3606 number. Being that there's so many census tracts across New York City, we can get relatively precise estimates of SDOH down to, in many cases, just a few blocks. Similarly here, you'll see New York City neighborhood tabulation areas, which were generated by the New York City Department of Planning. There's only 195 NTAs. And NTAs are based on census tracts. Therefore, conversion can be done with relative ease between census tracts and NTAs, meaning that if data is collected in one or the other, you could translate it to either or. During our research, we found that data was more readily available at the census tract level, so that led us to adopt this unit to facilitate data integration. From there, we mapped patient addresses to their associated census tract FIPS codes. For instance, we took patient addresses, we sent that to an API, such as the U.S. Census Bureau, and it was returned an 11-digit FIPS code. For instance, first, we strip raw address data of apartment-level identifiers and names to allow for maximum preservation of patient privacy. Next, we join the synthetic ID with a modified address to create a tuple, and we pass that tuple to the U.S. Census Bureau API. And the result was the original synthetic ID along with the 11-digit FIPS code for census tracts. Now that we've been able to link electronic health record data with outside estimates of social determinants in built environment, you may ask, what are the next steps? In relation to our communities and neighborhoods, we can begin to assess, well, how do they influence us and what is the magnitude of that influence? We can now link community level estimates of social determinants to individual electronic health records. We can also aggregate patient records to census tracts or other zones and perform community level analysis with external data. Another option is we can map patient locations while maintaining privacy and their proximity to other features such as parks, open spaces, hospitals, community centers, libraries, museums, you name it. Through all of this work, we've found that external data integration can be done with relative ease. Location-based linkage of non-personal data can be a reasonable proxy for neighborhood factors, especially knowing that individual level social determinants of health aren't collected regularly. And there's a need to develop composite measures that encompasses social and built environment factors, such as one called the neighborhood socioeconomic status, which incorporates education, wealth, occupation, and living conditions. Thank you for attending my presentation today. If you have any questions, feel free to email me at my address listed on the last slide here, or tweet me.